Good evening once again, everyone. We will be continuing on the histology of the pituitary gland. Learning objectives for this topic, or for you to be able to describe the normal anatomical position of where the pituitary gland is located, and to be able to describe the divisions of our pituitary gland, the anterior and posterior aspects of the gland, and also to differentiate between the histology of both neuro and adeno hypophyses. Also, we hope that you can differentiate and recognize the cells in the pituitary gland, the different types according to staining: basophil, acidophil, chromophobes, also the pituicytes, etc., and the various cells that produce the various hormones within or store the various hormones in the case of the posterior pituitary gland. And of course, to know their functions and understand and apply the clinical correlates towards the basic sciences that we have already discussed. So, I know that you've already discussed this in your anatomy. The pituitary gland is located in this depression within the sphenoid bone called the sila turcica, or Turkish for saddle. Okay? So it's located in this depression here. It weighs about zero point 0.5 grams in adults and is 10 by 13 by 6 millimeters. So a very small structure with very, very powerful functions throughout the entire body. It lies below the brain in a small cavity on the sphenoid bone, which is called the sila turcica, as we have mentioned. Okay, so it's actually an extension from the hypothalamus from the brain for the posterior aspect, and from the developing pharyngeal pouches for the anterior aspects. Okay, yan. The other term for the pituitary gland is the hypophysis class. It is composed of a dual origin, with the posterior aspect being related to the neural tissue, and the anterior or adeno or true endocrine part of the pituitary gland uh, derived from the embryonic pharyngeal pouches. Okay? They are united anatomically within the sila turcica of the sphenoid bone. However, they have different functions. Yan. As you can see here, the embryology. Okay? So you will see the neural structures here, the neuroectoderm. Eventually, you will see the neurohypophyseal bud, which is the future posterior pituitary gland. Okay, the hypophyseal pouch, no, from the developing pharyngeal pouches, no, are the future anterior pituitary gland. Okay, so eventually they develop together, and you will now see more towards the adult-like structures of both posterior and anterior pituitary glands, no, with the pars nervosa, an extension, no, of the infundibular stalk from the median eminence of the hypothalamus, whereas the anterior pituitary is divided mostly into the pars distalis, the pars intermedia, and pars tuberalis towards the infundibular stalk. Okay, all of which is located within the sila turcica of the sphenoid bone. Although they are united anatomically, they serve very distinct functions. The anterior pituitary gland, a true endocrine organ producing its own hormones, whereas the pars nervosa of the posterior pituitary gland are for the storage of arginine, vasopressin, and oxytocin. Okay? Yan. So another uh, aspect, no, of the pituitary gland, we see the posterior pituitary gland with the pars nervosa, and the anterior pituitary gland with the greatest portion would be the pars distalis, in intermediate in between the pars tuberalis would be the pars intermedia, and the pars tuberalis, no, surrounding the infundibular stalk. And in this portion, no, the median eminence of the hypothalamus. Yan. Okay. So in this photo, you can see the nuclei, the collection of neurons within the central nervous system, particularly the paraventricular nuclei, no, the nucleus that produces oxytocin for milk letdown reflex in nursing mothers, and also the myoepithelial contraction of the uterus, and the supraoptic nucleus that produces antidiuretic hormone or vasopressin. Okay, so and you can see within the infundibulum, these hormones are being stored within the posterior pituitary as uh, when they are being needed already, they will be released. Okay? Yan. So the blood supply is quite complex, no? So let's try to break it one by one and slowly. You have basically two capillary networks. Okay, you have the primary plexus of the hypothalamic hypophyseal portal system and the larger secondary plexus of the hypothalamic hypophyseal portal system, and they are being joined together by the hypophyseal portal veins. Okay, so this is really important because these structures are highly vascularized so that the cells hormone secretions via their ductless systems are able to be distributed in the capillary networks and throughout the entire body. Okay, you also have the draining hypophyseal veins, no, at the inferior aspect. The primary plexus is located by the infundibulum, no, and the pars tuberalis, whereas the secondary plexus of the hypothalamic hypophyseal portal system is located mostly here in the pars distalis, okay? Which composes most of the weight and dimensions of the pituitary gland. Again, they are being joined by the hypophyseal portal veins. Let's go to the neurohypophysis. Retains many of the histological features of the brain tissue. Again, they're derived from similar embryologic origins, no? From the developing brain, and consists of large part the pars nervosa with the pituicytes. No, they are orange staining cells that have variable morphology, and it also contains the infundibular stalk, no, the stalk-like projection, no, from the median eminence of the hypothalamus. Okay, adenohypophysis, on the other hand, no, or the anterior pituitary gland, is derived from the ectoderm and the developing pharyngeal pouches, no, Rathke's pouch that forms the true endocrine portion of the pituitary gland. So the adenohypophysis is being divided into three portions, as we have already mentioned. The pars tuberalis, no, closely in opposition with the infundibular stalk, pars intermedia in between the two, and pars distalis, which accounts to about 75% of the anterior pituitary gland, no, and enclosed by a thin fibrous capsule. You can see there are several types within the pituitary gland. Chromophobes that like to resist staining, pale staining, acidophils, also called alpha cells, that take up the acidic dyes. Therefore, they are reddish in color. The basophils, no, also called beta cells, have affinity towards the basic dye. Therefore, they are more bluish or purple in staining, and the pituicytes that are within the pars nervosa of the posterior pituitary gland, they are orange with variable morphology. Okay, The cells in the pars distalis, which makes up about 75% of the anterior hypophysis, are well stained endocrine cells with, as you can see, the interspersed sinusoidal capillaries herewith. These are red blood cells there, no? So because of the rich capillary hypothalamic hypophyseal portal system, you have a rich blood supply there. Okay? And you will see later on that these cells are actually very prone, no, to the effects of necrosis due to low blood supply. For example, in hypotension or hypovolemia in pregnancy, these cells are quite sensitive and may die, no, in cases of Sheehan syndrome, no, where you have pituitary cell necrosis. Okay, so they also have supporting reticular connective tissue that holds the architecture of the cells and the structures together. Here at the pars nervosa, no, you will see the orange staining nuclei of the pituicytes with variable morphology. Also, you can see, no, some follicles, especially, no, towards the infundibular stalk and the pars tuberalis, those portions with colloid. Yan. Pars intermedia. So you see the cystic follicles. Yeah. Take note, no, of the acidophils, also called alpha cells, basophils, also called the beta cells, no, and the chromophobe cells that like to resist staining. They are quite pale staining. Okay, so usually on histological section, as I have discussed with you, we can use hematoxylin and eosin, no, eosin being taken up by the acidophilic cells, and hematoxylin usually being taken up by the basophilic cells, as they have different affinities towards the different charges of the pigments of the dyes being applied to them once they're being processed and stained. Yan. So chromophil cells, no, are those that like to take up the stain. Okay? They have a lot of cytoplasmic granules within them, no? So chromophils are either acidophilic, no, like to take up the reddish stain, or basophilic, more the purple or bluish stains. Okay? They are have a high affinity to the acidic components, no, of our stain versus the basic, no, or that's why they're called basophilic in classification. Chromophobes, on the other hand, no, are clear, no, to very light orange in color. Okay? Yan. So clear. They do not stain readily. Okay? And as we have mentioned, no, chromophils like to be stained either red or blue to purple if they are acidophils or basophils respectively. Yan. In this table, we can see the various cell types, no, and what their hormones that they produce are, and what the major functions are as well, no. So most of the total cells, no, of the anterior pituitary gland are what you call somatotrophs, about half, no, or 50% of the total cell population, and it produces somatotropin, no, also known as growth hormone. Okay, and it stimulates the growth, no, in children, no, and in adolescents before the closure of the epiphyseal plates within the long bones, no, via stimulation of insulin like growth factors within the liver, no. So growth hormone affects the chondrocytes, no, and the developing long bones, no, and also influences, no, the metabolic rate, also influences the function of insulin, and also for the homeostasis of glucose. However, no, the major function is really for growth, okay, via the stimulation of insulin like growth factors that are produced in the liver. Okay, 15 to 20% of the total cell population are called mammotrophs or lactotrophs, no, that produce prolactin, no. As we have mentioned, no, prolactin uh, allows, no, the breast in new mothers or pregnant women, no, to develop, no, the mammary lactiferous ducts, no, lactiferous tubules, no, preparing the woman for eventual nursing, no. So lactotrophs or mammotrophs produce prolactin that promotes milk secretion. Gonadotrophs, on the other hand, that comprise about 10% of the total cells no produce follicle stimulating hormone and luteinizing hormone. Okay, so FSH promotes ovarian follicle development and estrogen secretion, of course, in women, and promotes the spermatogenesis in men. Okay, whereas luteinizing hormone promotes ovarian follicle maturation and progesterone secretion in women and interstitial cell androgen secretion in men. No, so FSH and LH, no, and in that vein, no, HCG, no, they are quite similar in terms of the chemical and molecular structure. However, they have specific subunits that are different, particularly the beta subunit, no, that allows us to differentiate them. And they also have different functions, no. So FSH, no, for estrogen secretion, okay, for women, no, and spermatogenesis in men. So make sure you familiarize that. About 5% of the total cells are thyrotrophs, no, that produces, no, your thyroid stimulating hormone, as we have already discussed, okay? And it stimulates thyroid hormone synthesis within the thyroid glands, no, or triiodothyronine and thyroxine, T3 and T4, okay? That's basically the function of your thyrotrophs within your pituitary gland. The corticotrophes produce adrenal corticotropin or adrenocorticotropic hormone, okay, and it stimulates the secretion of the various hormones in the adrenal cortex, so it affects the adrenal glomerulosa, fasciculata, and reticularis, portions of the adrenal cortex, for the mineralocorticoid, the glucocorticoid, and the androgen part, but mostly for the production of cortisol, which is the stress hormone within the adrenal cortex. Okay, so adrenocorticotropic hormone being produced by the corticotrophs, and about 15 to 20% of the total cells are of that type. Also, lipotropin, helps regulate lipid metabolism. Okay, not very widely known, unless we dive into the books um, deeper. Yan. The pars tuberalis, related to the infundibular stalk, this is a part of the anterior hypophysis or the anterior pituitary gland. It's a small funnel-shaped region surrounding the infundibulum of the neurohypophysis, this IS, infundibular stalk portion. And most of the cells of the pars tuberalis are gonadotrophs, so those that produce follicle stimulating hormone and luteinizing hormone. This portion here, funnel shaped, the pars tuberalis. The pars intermedia, in between the other two portions of the anterior hypophysis, is a thin zone of basophilic, purplish to bluish staining cells, and it lies between, the pars distalis and the pars nervosa. The pars intermedia usually contains, as we have said, the colloid filled cysts of various sizes, and during fetal life, this region produces pro-opio-melanocortin, and although not fully understood, this is eventually cleaved, into various sub hormones, and sub molecules, that play a role in the control of inflammation and also of the stimulation of melanocytes, for melanin production. This is why uh, in certain conditions, you will see later on in your clinical correlates that pro-opio-melanocortin excess production can cause hyperpigmentation in the skin. So try to research what condition that is in, where POMC like molecules are being produced that causes hyperpigmentation, of the skin, the bronze coloration. Again, the melanocortin, eventually, is being cleaved into various other uh, smaller molecules, no, and hormones, no, including two forms of melanocyte stimulating hormone, no, gamma LPH and beta endorphin. Okay? Melanocyte stimulating hormone increases the melanocyte activity within the skin. Okay? So to produce melanin pigment. However, no, the overall function and its significance remains uncertain. Yan. So suffice to say, in the pars intermedia, you will see the colloid producing follicles, no, that has POMC. Okay, so as we wind down, we will go towards the clinical application. Benign pituitary adenomas, no, can produce, as you have already discussed, no, about 50% are somatotrophs that produce somatotropin or growth hormone. Okay, so adenomas are hyperproliferation, no, of these types of cells, no, mostly, no, they can produce gigantism or acromegaly depending on the age of the patient. In this patient, no, where you see very prominent jawline, frontal bossing, no, and to some extent, no, hypertension, uh, this is acromegaly, no. So when the hypophyseal plates have already closed, no, no long bone growth can already be noted, you will see acromegaly. However, if the adenoma or the hyperproliferation of the somatotrophs and the production of growth hormone was excessive during adolescent or in childhood development, you can have gigantism. No, however, there is no clear cut. No, usually those with acromegaly have features of gigantism, even though the hypophyseal plates have already closed, no, so there is some overlap. um, Suffice to say, no, gigantism primarily occurs, no, before the epiphyseal, rather, plates have closed, no, in children, and acromegaly is seen um, among those with adenomas who are already adults. Okay, let's go towards the neurohypophysis or the posterior pituitary gland. As you have learned, no, it is not a true endocrine organ. However, it stores the hormones that are being produced by the hypothalamus, no, and it has a lot of neural connections. It is composed of neural tissue, and unlike the adenohypophysis, it does not synthesize its own hormones. It contains about 100,000 unmyelinated axons, no, and large secretory neurons, no, with cell large prominent cell bodies, also known as the herring bodies, no, in the supra from the supraoptic and paraventricular nuclei of the hypothalamus, no, for arginine, vasopressin, and oxytocin storage and eventual release. Okay, here you will see the pituicytes in the pars nervosa. Okay, so these are the pituicytes that have a variable morphologies, no, and can be orange in staining, no, small orange stained cytoplasm that are diffuse and barely visible, no, and you can also see, no, the herring bodies where there is accumulation of the hormones that we have discussed. Arginine, vasopressin, also known as antidiuretic hormone, and oxytocin are being stored in the neurohypophysis or the posterior pituitary gland, specifically in the pars nervosa. They are transported axonally, no, as this is a neural tissue, into the pars nervosa, and these hormones accumulate, no, as the uh, dilations called the neurosecretory bodies, no, or herring bodies. Okay, so they are faintly eosinophilic, no, reddish in staining, and these are the pituicytes, no, that have variable morphologies, no, variable in appearance with orange staining nature. Okay, lightly orange staining and diffuse. Okay, with these dilatations where we see are vasopressin and oxytocin being stored. So arginine vasopressin, also known as antidiuretic hormone, is released when the osmoreceptor cells of the hypothalamus are being triggered by increase in blood tonicity. So if the solute concentration within the plasma is increased because of dehydration, antidiuretic hormone is synthesized and eventually released. So ADH synthesis is seen in the supraoptic neurons, and ADH increases the permeability of the collecting ducts to water. Once you have mastered your Guyton, read it from cover to cover several times, hopefully, you will know that antidiuretic hormones uh, allows the reabsorption of water from the collecting ducts via inserting aquaporin 2 channels in the collecting ducts. Okay, so once you have aquaporin channels there, the water more readily is reabsorbed from the filtrate urine at that point back towards the bloodstream. Okay, therefore you will then have osmotic balance. So even if the patient or the person is dehydrated or there is some blood loss, antidiuretic hormone or arginine vasopressin allows normal osmotic balance to occur. Okay, to some extent, of course, unless the blood loss is already very, very extreme. Okay, so that is why the kidneys, the neural structures, the hypothalamus is very, very important in sustaining the life of an individual. Okay, so osmotic balance, the amount of dissolved solutes within the circulating plasma of the blood is being regulated by your antidiuretic hormone, and it affects the collecting ducts via the insertion of aquaporin channels. Oxytocin, on the other hand, is being released in response to, of course, the suckling of the newborn, or nipple stimulation, and the dilation of the cervix and also the cervical changes, no so that you will have contraction of the myoepithelial cells of the uterus during childbirth. And oxytocin, to some extent, is also being released during moments of bonding or hugging, because it is the hormone responsible uh, or contributing to the bonding of the newborn, or even among family members. Okay, so oxytocin, is a very, very powerful hormone that allows the very, very powerful contraction of the uterus that allows the expulsion of the fetus outside of the mother. Okay, also, the alveoli and the ducts of the mammary glands, allow the milk letdown reflex, So once the neonate suckles on the mother, the hypothalamus is being stimulated, and here, towards the posterior pituitary, you will have oxytocin, that allows the milk to flow, so that the neonate can feed. Okay? So the nursing infant is able to derive its food from its mother, and also the same when you reach your obstetrics rotation, especially if you are in a public hospital, one intervention that is being done in the public hospitals, usually or sometimes even the private, is instructing the mother to conduct manual nipple stimulation when she is in active labor, so that the labor will progress faster, because oxytocin also stimulates the contraction of the uterus, and the cervical changes, the dilation of the cervical opening, so that the infant can go out more quickly and more easily. So nipple stimulation can be done. However, in the private setting, you have synthetic oxytocin that is being infused into your mothers. Okay, so we wind down with the clinical applications. So you have several defects that can affect the vasopressin. There can be heritable mutations that can lead to ineffective antidiuretic hormone. So there is difficulty in osmotic balance, or by via the compression from a tumor or head trauma. No, you can have diabetes insipidus, where the individual no can no longer concentrate the urine, can no longer hold the the volume no of water within the blood, because antidiuretic hormone can no longer be secreted in those cases. No, so in lower levels of vasopressin, you will see diabetes insipidus, no, because the patient continues to urinate, no, even if the patient is already going towards dehydration. No, that would never occur in the first place if the ADH production is spared, no, or patent. Okay, so in this disorder, no, the patient is unable to concentrate the urine. No, the urine is very low in solutes, no, low in specific gravity, no, very watery, clear urine, no. And to compensate, no, there is increased thirst, because the osmoreceptors will also trigger the brain, no, for the individual to constantly drink water, because there is an impairment in the kidneys, no, ability to concentrate the urine, or the production of ADH, no. So therefore, the collecting ducts are unable to resorb the water back into the bloodstream. Okay, that's diabetes insipidus. Yan. Another clinical application would be in Sheehan syndrome. Usually, this is seen no, in a postpartum woman, whereby blood loss or hypotension causes necrosis, no, or inflammatory cell death of the cells of the pituitary gland. As we have mentioned, they are very, very sensitive, no, to being deprived of blood supply and oxygen, no. So postpartum pituitary gland necrosis leads to a lot of the effects of the absence, no, of the pituitary derived hormones. Okay, so this usually is seen, no, though rare, no, associated with excess blood loss, no, or hypotension, decrease in blood pressure during childbirth, no. So the mother can have a failure of lactation because there is no prolactin, right? And there can be absent menstruation, no, when it would be expected, because there is no more luteinizing hormone and follicle stimulating hormone, and also prolactin. And you can also have features of hypopituitarism, right? Secondary hypopituitarism, no, because this affects the pituitary gland, no. You can even have hypothyroidism, because there is no TSH from the pituitary gland, or cortisol deficiency, right, from the adrenal cortex, because there is no adrenocorticotropic hormone. So it depends on the extent of the necrosis, okay, and the number of cells, no, and the type of cells that are being affected, no, in Sheehan syndrome. No, we have already discussed, no, diabetes insipidus. It can be central, no, via the destruction of the neurons, no, or mutations in the arginine vasopressin, no, the antidiuretic hormone production, no, whereby you have a reduction in the release, no, therefore the urine is unable to be concentrated, there is excess urination, no, and there is thirst, no, and the patient, no, will be dehydrated. Okay, that's central diabetes insipidus. Okay, so nephrogenic diabetes insipidus, on the other hand, is when the kidneys have a resistance to the antidiuretic hormone, or the arginine vasopressin. No, so the aquaporin channels, no, are not being inserted into the collecting ducts, and the urine cannot be concentrated. No, so there is a decrease in the specific gravity, very watery, clear urine. No, that's what happens in nephrogenic diabetes insipidus. No, there can be mutations in the aquaporin channels. Okay. Also, no, rarely you can have gestational diabetes insipidus, because of the excessive activity, no, of the placenta derived vasoprenase, no, which causes antidiuretic hormone degradation. Okay. So not very common, however, no, sometimes it does happen. Okay. So you have a decrease in the reabsorption of the water, no, so you have an increase in the solute-free water diuresis, no? So what's being excreted in the urine is very clear, no? Very watery urine, no? That should not be. Okay? Because the body has a strict, no? Very regulated homeostatic mechanism for the osmolarity, no? The amount of dissolved substances circulating within the plasma of the person. And that's basically it, no? Try to read more on your Onkera and Robin's pathologic basis of disease, no, for the clinical correlates, and also, no, even your Guyton physiology for the physiologic concepts. Okay, so I wish you well in your exams. God bless everyone, and I will be praying for you. Okay, so keep at it. Thank you, everyone, and God bless.